Welcome everyone. Welcome to this second session of the Scleral Lens Certification Course. And I'm very happy to introduce our speaker for today. Today we have Dr. Daniel Fuller. Dr. Daniel is a very experienced academician as well as a practitioner, I would say. He earned his degrees way back in 1980 and 1984, where he got his PhDs in qualification. He began his career in a hospital-based setting first in the US Navy, serving for 8 years. And then he spent about 17 years in private practice as the owner of the multi-site solo practice, which emphasized on medical eye and specialty contact lens services. He has been into academia since 1987 and currently is in the rank of professor and is the chief of the cornea contact lens services and also the founding supervisor of the cornea contact lens refractive surgery residency at the Eye Center in Southern College of Optometry. He lectures internationally and has authored numerous peer-reviewed publications and papers presented at various national and international conferences. He is also a diplomate in the Cornea Contact Lens and Refractive Technology section of the American Academy of Optometry and also a fellow of the Scleral Lens Education Society. He has held many positions and chaired various leading organizations serving local, state, and national level. And currently, he is the vice president of the Scleral Lens Education Society. I mean, wonderfully, SLS has been very kind enough to run this program, to run this show, and bring in so extensive speakers, experience, in terms of scleral lenses to talk to us over these 11 session course. And I would like to welcome you, sir, onto our platform. Let me leave the screen time to you.
Thank you so much. And it's a great privilege to be able to address the group. Deep appreciation to the organizers of the meeting. And it's clearly a very well organized group. And it's my privilege to present to y'all. So here you can see my disclosures as to what I'm affiliated with and nothing I talk about in today's lecture do I have any financial interest in. So what I wanted to do today was basically go through the basics of Scleral Lens Fitting and the basic troubleshooting. We're not going to go into a great deal of depth about complications another day, but I wanted you to be able to go through and recognize which patients will benefit from these technologies, how to basically fit these lenses using an evidence-based approach now that we have a fairly large body of evidence out there now as to what works and what doesn't work, and to recognize some of the common fitting issues that you'll run into so you'll be able to troubleshoot those and also be able to recognize complications that you may have or be able to predict when you might have complications. I wanted to start with basic nomenclature. And a few years ago now, many of the folks were out there and still are out there using a variety of different terms. Some of them go back to when we first started fitting scleral lenses back in the 50s and 60s. But what we tried to do within the Scleral Lens Society was to organize the nomenclature into a consistent format. And it's our hope that over time, this nomenclature will be adopted. And there is a paper that is available where the nomenclature is laid out in greater detail. But these will be the terms that I use today as we go through the lecture, terms that were devised by a group of our experts, and hopefully over time, industry will adopt those. The problem you have always with industry is that they have many proprietary terms for their own individual products, and so they may be a little bit resistant to adopting some of this nomenclature. But in general, we'll talk about the optical zone in the center. We'll talk about the transition zone that joins the optical zone to the landing zone. And then we'll talk about the edge as we go through. Also, you want to be able to get oriented so that you can see the different zones of the lens as it's sitting on the eye. And And the challenge is that when you're fitting the lens initially, you can fill the bowl with saline and also put some fluorescein into it to highlight that tear reservoir thickness so that you're able to visualize that clearance much easier. When the patient comes back for the follow-up, you'll want the lenses to be settled for a couple, 2 to 3 hours. And when you do that, you're not going to obviously have fluorescein coming in under the lens. You can sometimes paint the edges of the lens and try and get the fluorescein to leach in around the edges and exchange into the lens, but that's a lengthy process. So you have to also get very capable of visualizing these zones as you see them just under white light with no fluorescein in the reservoir. And that takes some practice to get to that point. But in general, as you see the light coming from the left side to the right, you'll see the lens surface will be the first zone. And as you inspect your lens and your patient when they come back, it's always good for you to look at the condition of the lens. It gives you some insights into how the patient is handling the lens. Also tells you whether or not they're having any problems that may be contributing to a decrease in vision with the lens as well. So look for scratches using specular reflection off of the surface of the lens. Look for deposits. All these things are helpful in trying to identify potential problems that the patient may be having. And then the next zone over will be the actual lens thickness. And because it's an optically vacant space, it'll be a dark area in between that surface of the lens and the reservoir. And the reservoir thickness with or without fluorescein in there then is the next one over, and that's the one that we tend to obsess over. And then we'll look at the corneal thickness, which is the largest expanse typically in the next zone over. And that brings us to a good point about talking about clearances. When we talk about clearances, the biometric ruler that we use will be not the corneal thickness, because that will vary depending on the pathology that you're fitting. So if you're fitting a keratoconus patient, you can't assume the thickness is 540 microns or so like you would in, say, a normal cornea. And so we'll actually use that optically vacant thickness, the tear lens, or the actual center thickness of the lens, to kind of create a ratio, because that's a known value that we have, and we can make a ratio of that to the tear reservoir thickness as well. Other terms that we're going to use, it's important when we talk about these lenses that we're not just talking about curvature values, which is what the back optic zone radius gives you, but also talking about the shapes of the eye. So the normal shape of the eye is a prolate shape, where it's steeper in the center and flattens out towards the edge. But there are many pathologies, particularly post-surgical eyes, where you have a lens that's flatter in the center, but then it becomes steeper out towards the edge of the lens. So we have lenses that are available in either sort of design. And so we think about not just curvature data, but we think about the shape data when we're trying to select a lens. And you can see here on the lower left side that we have two lenses with basically the same overall diameter, and that they've got very different shapes there. And those shapes are reflective of the type of pathology, again, that you're trying to fit. When we talk about those parameters that are most useful for identifying whether you have a well-fitting lens or not, we talk about back optic zone radius, and that typically will have some control over the amount of clearances you have, particularly out in that transition zone area. But what we're really interested in most of all is the sagittal depth of the lens. And the sagittal depth of the lens will vary even with the same back surface, back optic zone radius. So here you can see in the lower right-hand side that I pulled a couple trial lenses from our sets that have the same back optic zone radius, but they have very, very different sagittal depths because they may have very different diameters. And so it's important to recognize that. And if we look over on the left-hand side on the bottom too, you can see there that with the lenses that are showing the black dots there, that depending on what that diameter is, even with the same radius, you'll have very different sagittal depths. And that sagittal depth has a lot to do with how that lens fits, whether it's loose, whether it's tight, and whether the patient's going to get a physiologically healthy fit out of it. And also, when we try to adjust these parameters with your labs, and I really encourage you to get to know your lab people very well, because their consultants are really helpful for fitting these things and adjusting things, because some products you can adjust the individual curves independent of each other. So I can change the transition zone without lowering or raising the sag, for example. In other products, the two are conjoined so that if I change one, it's like a hinge effect, that if I flatten one, I may lower the sag. If I steepen the transition zone, I may increase the sag. So you have to know the products that you're dealing with too, and be able to communicate that effectively to your labs. As you get more expert, you'll be able to manipulate these curves independent of each other. When we look at who are the patients that are most likely to benefit from these technologies, there was a group, and it's still active, producing publications now, the Scleral Lenses in Current Ophthalmic Practice Evaluation Studies, the SCOPE group, that looked at this early on. And when they surveyed practitioners, what they found, not unsurprisingly, was that 74.2% of the patients who are fitting in these technologies are irregular corneas, and only 25.8%, which is actually a pretty high number, are patients with regular corneas. And so these may be patients that have high amounts of astigmatism, that haven't done well in soft lenses or have had poor optics. They may be folks with dry eyes and have normal shapes and topographies to the corneas. So there's a variety of people that we may fit. There may be issues where we fit them in a multifocal scleral lens because they weren't getting centration of the multifocal optics in a soft lens design or that sort of thing. But the overwhelming majority of these are going to be irregular corneas. And within that group, you can see, regardless of whether you're an experienced fitter or new to fitting, the vast majority of these patients are going to be keratoconus patients or some version of that. And then the post-surgical eyes fall into the next kind of bucket after that, or the next group. When we look at the relative contraindications for fitting, and I say these are relative contraindications because some of these things that I'm going to list out here are actually reasons to fit people for lenses. So, but one of your thought processes as you go through fitting these patients is who's at risk for inducing complications from the fit, and who am I less concerned about having complications with? So there's not a consensus on what the threshold is for looking at endothelial cell densities or endothelial cell counts for when you fit the lens or not. Most people in the literature are suggesting that you need to start thinking about that at about 1,000 cells per square millimeter or less. And I've got certainly patients that are in the 400 to 500 range that so I can only do that if I know where they're at when we start. So I like to, on my particularly at-risk corneas, I've got a specular microscope. So it sounds like I'm maybe having some trouble with my audio. There we go. Having a specular microscope may not be a luxury that you have in your practice, and you can try and make some judgment looking at the morphology using a specular reflection off the endothelium. But it is helpful to know, and if the cornea specialist has access to these things, you may want to send the patient back to have those cell counts checked if you're particularly concerned about the patient. But even as ugly as this graph looks over here on the right side with the scarring around the host graft junction, having a clear center is important, looking for epithelial, stromal, and endothelial rejection. But knowing who's at risk and who's not at risk kind of guides your thought process in whether you need to maybe use a hyper decay material of the highest sort, or whether you need to reduce the wearing time down, or maybe that you want to have a minimal clearance over the graft, those kind of things. Folks with vitreous or retinal surgery are a little bit more risky cases where you may have more challenging fits. You may have obstacles to work around anatomically and man-made iatrogenic obstacles where you have tubes and shunts. You don't want to cause an erosion of a bleb or an erosion of a shunt where somebody's had a glaucoma surgery, for example, back in the literature now looking at whether or not any compression from scleral lenses contributes to a worsening of glaucomatous eyes over the long term or not. It's a very complicated subject. We try to look at how we're obtaining that data or not. The general thought is that with normal corneas, there's probably enough auto-regulatory function that we don't have to worry about it. But when you have folks that have tubes and shunts and multiple glaucoma surgeries, those are high-risk cases, and it doesn't take much of a change at all to alter their outcomes in terms of the control of their glaucoma or not. So, it's something that you need to watch closer in those patients. You may still want to go ahead with the scleral lens fit, but you're going to heighten your awareness and track more closely what that patient's health status is over the long term. Folks that have keratoplasties, again, we know that they lose the majority of their cells shortly after the keratoplasty surgeries, and we're going to go through a little bit of that data to help you. But considering who's at risk or not, we want to make sure that we heighten our awareness again. So here you can see that roughly between 70 and 75% of the cells in a graft are lost in the first 5 years after the graft is provided. So we do know it slows down in terms of loss. I had a patient in just this past week that had a graft 36 years ago and in each eye. And it's still a well-functioning graft, very clear, doing great. She's clearly an outlier tell people that, if they get a good 10 years out of their grafts, they're doing well. And there's a difference then, of course, as to whether you're doing full thickness grafts or partial thickness grafts and how they do over the long term, whether they're decreased risk or increased risks of rejection going over the long term too. So I won't belabor this data other than to just put that out there for you. That, we're seeing the point as to whether we're doing full thickness or partial thickness grafts these days. And one of the roles that we play in this as eye care providers is that we can actually decrease the demand side for the grafts. So again, our ability to keep these patients out of the OR is very, very important in terms of decreasing the demand for grafts, because we know, just like all transplants, there are many more people that would like to have those than have donor tissues available. Okay, so when we look at major complications, this has been a subject of great interest within the Scleral Lens Society and also with the International Forum of Scleral Lens Research that I'm part of. And we're actually undertaking a multi-site study that we just received a $100,000 grant to pursue, looking at microbial keratitis and scleral lens wearers. But the original data that we had goes back to a time when the lenses were being made out of PMMA material, and it was at the dawning age of gas permeable lens materials. And because of the concerns and lack of good technologies at that point, we kind of shelved that technology for almost 30 years before we came back to it. But you can see here what I've done is I've kind of graphed out what the complications are or most commonly encountered are. And if you look at those, I've kind of broken them at that yellow line between those things that are lens related and those things that are physiological complications. And you can see overwhelmingly that the problems that patients encountered in the early days were things like neovascularization, discomfort, corneal edema, things that we might attribute to hypoxia. When we look at the adverse events related to lens problems, they were largely an issue of keeping the lenses clean and maybe challenges in fitting the lenses over time and handling the lenses over time. So it's interesting when you break them out that way. There was a second part of this study that was done. If we can get to that. where they actually had gas permeable lenses coming into greater utilization. And what we saw was a decrease in complications associated with hypoxia. And so this told us that one of the limiting factors we had was the technology of the lens polymer itself in terms of mitigating these potential physiological complications. So we've tried to do some additional studies since that time, and we actually did a study with my residents, 2 different residents, 2 different years, and presented these results at the Academy, and some of these results actually got published in the American Academy of Optometry's journal, Optometry and Vision Science. And what we found was the overall complication rates were fairly high if you counted in the lens handling issues, but they're relatively low when you start looking at what the physiological issues are. And the lens handling issues and lens care issues are, very controllable, very manageable. The physiological issues, a little bit harder to get your hands around in terms of how often we see these or the epidemiology of them. Some of them we know from experiences with post and corneal GP lenses are related to how those products are being used or how those devices are being used in terms of the care systems, in terms of overwear issues, and so on. When we look at issues again in not just keratoconus eyes, but eyes that have had surgery, those eyes that we might consider to be at greatest risk for having problems, we can see that they break along similar lines, and the risk of infections are probably higher in those eyes, not surprisingly, if they have lack of intact surfaces. So we have many patients that come in that we get referred from the ophthalmologist in town that may have things like neurotrophic keratitis, that may have had ulcers, that may have persistent epithelial defects, that may have things like Stevens-Johnson syndrome or cicatricial pemphigoids, things where their ocular surface is constantly at risk because it's exposed. So these are patients that we're concerned about infections in and watch more closely. If we break these again into basic groups of saying what are the types of things we see on the physiological side, you can sort of break them down into hypoxia-related problems, inflammatory-related problems, and infectious problems. And then on the other side, you have fitting challenges, and these are things that relate to the interaction of the lens itself and mechanically with the surface of the eye, or how that device is being maintained over time. And you can see here that some of that's related to asymmetries in the profile of the sclera. Some of that's related to a lens being too tight and binding. Conjunctival prolapse is an interesting kind of condition. Here's a picture of it down in the left-hand corner where you can see the conjunctiva sort of pulled up in under the lens into that transition zone and bunching up there. Thought to be a benign condition, maybe more concerning if after you take the lens off that conjunctiva doesn't fall back to its normal position, but maybe adheres to the cornea. Those may be more concerning types of cases, but in general thought to be a benign condition. Limbal bearing, that's where the limbal stem cells are, so we're always concerned about that. Midday fogging is a real interesting condition, and the things that contribute to that may be partially related to the lens itself. And epithelial bogging, you can think of that as being sort of like when you're sitting in your bath for a very long time and your skin starts to wrinkle up. It's thought to be a side effect of being immersed in the saline in the reservoir for hours and hours and hours, that the cornea itself actually sort of wrinkles a little bit. All right, so let's get into what you're really interested in, which is the actual basic fitting. And what I've tried to do is I've gone through and I've tried to state things as the principle that we're trying to express, and then we talk about the rationale behind it and ways to address the problem. So what I've done here is I've pulled up a Google map of where the college is, and that's over here on the left-hand side and towards Memphis, Tennessee. We're in area called the Medical Center. And then my favorite corneal specialist is out on the right-hand side of the chart at Eye Specialty Group. And what I've done for you here, what Google does for you, is it gives you many different ways to get to the same destination, right? So the first principle I'll give you is that when you start to fit these lenses, set an objective, establish those objectives, and then make sure you and the patient agree on the objectives. If the patient has unrealistic expectations, you're less likely to end up with a successful fit. Even if it's a mechanically successful fit, the patient may be disappointed because their expectations exceed what the capacity for that device to deliver on is. So make sure you set your destination and that you're in agreement on where you're wanting to go. So are you trying to fit these lenses for visual rehabilitation? Are you trying to relieve the symptoms that the patient may be having, say, particularly an ocular surface disease or cicatricial pemphigoid or those kind of things? Or are we trying to preserve the ocular surface so it's not scarring over with one of those conditions? And it may be a combination of those things. But it's always good to start out with your destination in mind so that you realize when you get there. And this is a lesson that my students have a hard time with in terms of starting out with these things, that the goal is not always to get the patient to 20/20 in vision or 6 meters over 6 meters. The goal is to get the patient happy. And if the patient is happy and the physiology is preserved, then we've got a success. And if we can improve their vision along the way, which is very common, and we've shown through multiple studies now with multiple different types of pathologies, we're capable of providing significant improvements in vision with these devices, then that's great too. But you want to know from the outset as to what your goals are. As you start fitting these lenses, you have a variety of different ways you can do this. You can do it with the traditional trial lens fitting, which is, I think, what most of us are doing. And if for those that are the Jedi Knights out there of this technology and are capable of working on a more advanced level, then using some of the newer technologies to fit these lenses is something that you're likely to start doing. So at the college, we've got several different devices that we can work with. We've got an SMAP 3D. We do not have an eaglet profiler, and we don't have the iPrint Pro device because of the type of populations we serve that better fits our needs this way. But we also have Wave software, and we have iSpace and a number of different technologies that allow us to customize the design of the lenses even before we submit them to the lab. And use basically the trial lens only for the over refraction that we're trying to get. So the advantages are that you may end up getting better optics if you're actually trying the lens on, and you can align that lens with the scleral profiles. It eliminates the necessity when you're doing these empirical fits of having to maintain the trial sets and trying to have to put up with cleaning and decontaminating multiple trial lenses. And in eyes that have got very fragile corneal epithelium, you're not wanting to try on multiple 4 or 5 sets of lenses for fear that you may cause an erosion while they're in the office. So there are some advantages to doing the empirical fits, but it's not at a point yet, perhaps except for the iPrint Pro, of where we can actually just take those measurements, send it out, and have a lens produced without at least getting an over refraction, because you still have to at least go through that step. But it can simplify or streamline that process greatly. And when you're starting out, you may find that you have to do more trial lenses rather than fewer trial lenses as you get the more experience. We actually have studies that have shown that there is a learning curve involved. And one of the studies looked at basically just a couple fitters. So it was a rather small sample size. And they were fitting a number of consecutive lenses. And with this individual, it took 60 fits before they saw an improvement in the reduction in the number of trial lenses they needed. You may be a faster learner or a slower learner than that. I think 60 lenses is probably a lot of lenses to have to learn before you, or to do before you get to the point where you're proficient at fitting these things. I've got students that become proficient after fitting 2 or 3 lenses. They obviously want to take on less complicated than more complicated cases, which is where I would suggest all of us start fitting these things. Don't take on the most complex patients to fit, but start fitting the easier fits like the keratoconus fits. And you'll develop your confidence and competence as you go through that process. But I don't think it realistically is going to take you 60 fits to get there. It really depends on how much support you get, how much time you put into learning about the technologies, any wet labs you attend. There are a lot of ways that you can simplify that process. But in any event, it is something that requires some experience over time to get better at it. We actually did a study at the college and had this published in Optometry and Vision Science. And what you can see here is right and left eye, and then you see a difference between those fit with OCTs and those fit just by clinical observation. And what we found was that when you first start out fitting these things, you're more likely to overestimate the amount of clearance than you are to underestimate the clearance. And the more shallow the clearances are, the greater the magnitude of your error is going to be in that overestimation. So if you're concerned that you're going to fit a lens too flat, you're more likely to fit a lens with excessive clearance than to fit a lens with insufficient clearance as you're starting out. So that gives you sort of a benchmark in a way to kind of frame it in your mind as you're starting to do it. And again, this was kind of mirrored in other studies by other authors too, that found similar sorts of experience about the magnitudes of that overestimation as well. So let's go to our second guiding principle as we're fitting these lenses, that as the corneal irregularities increase at any one point, so if they're getting steeper and steeper and steeper, for example, in terms of curvature data, or if they're covering a wider area, or the lens or the apex of the irregularity becomes more eccentric and rather than central, then you're going to move from smaller diameters to larger diameter lenses in order to bridge those irregularities. So that's a general statement that we can make about selecting the diameter of the lens, that if you've got a very steep cone and you've got a very decentered one, say a pellucid degeneration versus a nipple cone, you're going to end up selecting something with a larger diameter as well. And it's thought that the larger diameter lenses redistribute the pressure of the lens resting on the ocular surface over a larger surface area. And so there's less bearing with those than there are with smaller diameter lenses. And we'll see this again when we talk about settling in a minute. As we try to pick overall diameters, again, as we try to make categories of patients that we're fitting these on, they tend to be smaller for ectasias and they tend to be larger for ocular surface disease patients. So if we're trying to protect the ocular surface, we're going to maybe go in the direction of having larger diameter lens. Whereas if we're fitting a keratoconus patient, the average patient, we can get away with a smaller diameter lens. Beyond that, there's really not a consensus on what goes into diameter selection. I would tell you that one of our meeting organizers, Dr. Fidel out of Italy, has written some nice papers on this. And she's made some suggestions in how you might approach this in a more analytical way of selecting a diameter here. So you can look at the horizontal visible iris diameter. That's the HVID there. Or you can look at the scope survey findings that said that the average fitter is fitting something in and around that 16 diameter range, something maybe 15 to 17 millimeter diameters. I can tell you that I don't often fit things under 15. There are occasionally patients that have smaller corneal diameters where I'm fitting something in a 14.8, but I'm seldom that small. I'm more likely to be in that 15.5, 15.8, 16 to 16.8, 17 diameter range. I do have some patients that are in the 18 millimeter or even a 20 millimeter lens. As you start to get that large, you're increasing the amount of toricity on the scleral profile, and it becomes a little more challenging to fit and get a good alignment out there on the edge. And also, as you start to get up towards that 20 millimeter range, you're starting to impinge on the insertion of the recti muscles, and that becomes a little uncomfortable for the patient as well. In the third principle, as we try to think about our landing of the lens and where it's going to sit, we have to think about the sclera. We're used to, as fitters, thinking about the corneal shapes and corneal profiles, but we are now having to think more about what's going on with the profile of the sclera. So the third principle is to understand if you have any impediments out there to a good uniform fit. And some of the common things we're going to encounter would be things like pinguecula, shunts, tubes, blebs, a host of irregularities like that. Another reason that you may be fitting larger diameter lenses again is if you have a decentered graft, which is not all that uncommon, or one that's tilted, then you may have to get a larger diameter to get clearances out in the transition zone, unless you're going to a semi-customized or customized lens fit like an iPrint Pro. But running into these obstacles is potentially sight-threatening to the patient. If you take a filtering bleb that's doing well and you put a lens on it, it's going to start to erode through that bleb, and you're going to lose the function of the bleb and open the patient up to risk of things like endophthalmitis. As you can see in this middle picture on the bottom, this is actually a patient that's had a pterygium excised, and when they had it excised, they still have an elevation there that we have to work over, and that still can become inflamed and agitated to where it may want to progress again. And so using little micro vaults over it, as I've done here, actually provided this lady finally with the relief that she needed. She was concerned about the cosmesis of it because it was still a very vascularized tissue even after the removal. And so it's going to look more hyperemic even when it's not, just from that post-surgery appearance. And so we tried Lumify on her, trying to suppress the redness, and finally ended up going with Alphagan to further cause vasoconstriction and reduce the redness that was bothering her so much. And then you can see over here on this bottom left-hand side where we have a fairly typical notch that we can put in on the edge of the lens to avoid a pinguecula that's standing more proud of the surface. And then we've done a similar sort of notch on the far left side to get around the bleb you see in the superior temporal quadrant there. So there are ways to work around these, and fitting these is a little bit of an art form too. And we can talk about those a little bit as we go through, but this is again where your consultants are very helpful. If you have scleral profilometry, it becomes much easier because we can actually measure the elevations in those areas and where they are very precisely. That makes it a little bit easier. Otherwise, we're having to make certain estimates and guesses as to how much clearance we need or not. And then we specify where these things need to be put in based on a radius. And then you have to try and get the lens to stay in that position. And they can do that with prism ballasting. We can do it with having toric peripheral curves and landing zones. So there's a variety of ways of stabilizing them. And you've got to teach the patient on how to rotate these lenses into the proper position to get that to happen as well. Our fourth principle that I want to share with you is, again, this difference between the sag and the base curve and how that affects the optic zone clearances. Again, we talked about that at the start, so I won't go over that in too much repetition here again. But again, larger diameter lenses are going to have greater sagittal depths, and smaller diameter lenses are generally going to have shallower sagittal depths for the same base curve radius. And this is ultimately going to determine the clearances that you have in the center. And if we look at an average range of clearances that we're trying to shoot for based on a variety of different studies out there, after settling is important because settling is going to occur in variable amounts. We'll talk about that in a second. But you want to end up with something that's generally in the 100 to 300 micron range of clearances. If we look at the rationale for why that is, well, we're thinking about the DK over T now as including not just the thickness of the lens as we're used to thinking about for soft lenses and corneal GPs, but also that scleral lens clearance is going to cause tear reservoir thicknesses that are substantial. And we have to add that into the T when we're thinking about our total transmissibility of oxygen across those different zones. And when we think about an oblate design versus a prolate design, oblate designs are going to oftentimes create a lot of central clearance in order to get over, say, the junctions of where the graft host junction is, or radiokeratometry, or intacts, or intracorneal ring segments, where you may have a corneal knee that you're trying to clear. By the time you clear that, you may end up with quite a bit of additional central clearances. So using reverse curve designs, reverse geometry designs, that's what the RG is here, may allow you to lower that central clearance while still having fairly steep transition zones. So those are ways to get around hypoxia concerns. The lacrimal lens, we know, is responsible for neutralizing the corneal astigmatism and improving the optics and reducing the higher order aberrations, but there is a limit to that. And so some studies have suggested that when you get over a 400 micron clearance in the center, you may start to lose some of the quality of your optics. And certainly we're working on things like wave error correcting lenses that are now available from a number of manufacturers. But even so, it's a little bit tricky because not all higher order aberrations are bad. Some of those actually neutralize some of the errors that are created by the irregularity in the corneas. And so we're still learning about how many of those higher order aberrations we do need to correct and which ones are most important. You can see here from a number of different authors out there what the suggested clearances are based on concerns, theoretical concerns, I would say, about hypoxia. What we actually find is that there's not a good correlation between the theoretical and those frequency of hypoxic events that we see in the clinic. If you went by the theoretical predictions, we should have been seeing a lot of rampant hypoxia out there. And the reality is we just don't see that. So we know that there are some errors in the models and flaws in the models in terms of the assumptions of the values that are used to calculate the transmission of oxygen across the different interfaces of the lens and the tear reservoir and the cornea. And so that explains why there's a difference there. But there is a fairly good consensus that using hyper DK materials, that's anything over 100 DK, is probably advantageous. Do you need to push something up as high as some of the newer materials that go up to 200 DK or not? Maybe not for everybody, but maybe those are the things that you hold in reserve for the patients that have compromised endothelial function, like some of the aging grafts that we talked about earlier. Maybe those are the people that need the 200 DK materials, and everybody else maybe does fine with something in the 125 DK range. So you can sort of titrate your choices based on your understanding of each individual patient. Since we fit patients, we don't fit populations. Some of this data has to be modified for who's sitting in your chair and can't be just applied across the board for all patients that you encounter. So when we talk about the risk of hypoxia, what do we know about that? Well, there's been some good studies done that suggest that when we go from a 200 to a 400 micron thickness, that we can decrease the amount of oxygen available to the cornea by 30%. It is interesting because Stephen Vincent has found that there is actually a threshold that when you get up to around 600 microns of clearance, you're no longer decreasing that amount of available oxygen in a linear fashion, that you kind of hit a plateau, in other words. So, there is a limit probably that we encounter, and what that limit is established by probably depends on both the demand for oxygen by the cornea, and also things that we don't fully understand yet, like the amount of tear mixing that goes on in the reservoir, the amount of oxygen being provided by the limbal blood supply, and other factors in terms of tear exchange and that sort of thing. So you would think that it would just get worse and worse and worse, but there is actually a plateau that's involved. We know that there is some hypoxia occurring even when the lens is well fit, and that's what this photomicrograph is showing us to the right-hand side here, where you can see the normal corneal endothelium in picture A, and as you look over in picture B, you can see some dark spots in the center. Well, those are the endothelial blood response that you see, and you also see changes in morphology, where you have more polymegathism and shape distortions in the corneal endothelium. So we know that even in a well-fit lens, we still see signs of hypoxia using changes in the endothelium as a surrogate measure. And we can actually measure now, and have measured through a number of studies, that there is some low background corneal edema that occurs that's under 2%, and it varies depending on the study that you look at, but in general, they're under 2%. And that value is kind of significant because we know that we get 5% corneal swelling overnight in a closed eye state just normally. But the difference is that within a half hour or so of opening your eyes in the morning, you reduce back down to back to the baseline of no swelling very quickly. When you put a corneal scleral lens on, I mean, the chance for that to regress is kind of cut short. So you never quite get back to the background or down to a baseline of zero swelling. You end up where you have this constant low-grade swelling going on through however many hours the patient may wear the scleral lens during the day, 12 or 14 hours, say, in some cases, that, we don't know what that low level of corneal edema that's constantly there causes to the physiology of the eye over the long term. So there's a lot that we don't know yet about what the impact of that residual edema does throughout the day. And so that's somewhat concerning, and it's probably more concerning again for eyes that have less reserve capacity, the eyes that have compromised endotheliums like the graft patients, versus somebody that's maybe a keratoconus patient that may have otherwise normal functioning endothelium. So those are things to keep in the back of your mind again as you're thinking about the risk of hypoxia. Not all corneas are going to be the same again. I think this might be a good stopping point to maybe run some of those poll questions that we have as well, if you wouldn't mind.
Sure, sir, sure. I'll just put up the first poll, and there you go. So I've launched the poll, and if you guys can answer that, which error is the most common with new fitters estimating the optical zone clearance? Do you think they overestimate, they underestimate, or probably they are accurate, or there is no trend which is seen? Okay, so I'm gonna keep this on for the next 10 more seconds. Great. Okay, so I think Dr. Daniel, you can see on the screen as well.
Yes.
Yeah.
Thank you. So the correct answer, yes, overestimate. So we, particularly as we start out, we're more inclined to overestimate the amount of clearance than we have than underestimate the amounts. And when I first put a lens on an eye, we generally like the lens to settle for maybe 20 minutes or more. And we'll talk about that in relationship to settling times in a second here. But you don't have to wait 20 minutes for a lens that's obviously not fitting well. That's just wasting your chair time. So if you have a lens that's already compressing the apex of the cornea, then you don't have to wait 20 minutes to know that it's going to still look pretty bad after that period of time. So you can go to your next lens right away. Whereas if you have a patient that's excessively clearing, you've got bubbles in the lens and reservoir or tear reservoir and all that sort of thing. You don't have to wait for that one to settle either. So what I like to do is I'll just check with a transilluminator, or I'll look at just with one of those little pocket cobalt filters and blue lights, and just take a quick look. I may even put them behind the slit lamp and take a quick look to make sure that I'm not wasting my time for settling to occur on a lens that's obviously not a good fit to start out with. Okay. Is there another poll that we're ready to run there too that might?
Yeah, we can run that as well, sir. So there we go. I think this would be very, very close to what you just talked about, but nevertheless, I've just launched it.
Okay, thank you.
Yep. So how much does the DK over T decrease when the sagittal depth increases from 200 to 400 microns? Okay, so there you go. The poll is up. And yeah, so I think another 5 seconds more. Great. So majority is saying 30%.
Okay, so that's correct. 30% is the value that was found in the one study, looking at the change from 200 to 400 microns. But again, remember, as you get over that 600 micron threshold, there's actually a plateau effect that occurs. And again, just a reminder that we still don't know all of what we need to know about how we deliver oxygen to the eye and how that oxygen within the tear reservoir gets distributed. And so there are things like tear mixing that go on where you have a temperature gradient differential, where you have movements of the fluid in the reservoir that may help distribute that oxygen in a better way. And all the oxygen either comes in through the layers of the lens and the tear layer to the cornea, or it comes in from the limbus on the edges. We're really not getting much from the lid at all, like you would in an eye that's closed overnight. Okay, so let's pick up where we are. Looks like everybody's with me here.
Yep.
Go on. There we go. So as we think about that initial selection of the sag depth again, we're going to follow the fitting guide. That's one way that we can do it. And these fitting guides, again, the consultants at the lab have spent a great deal of time trying to standardize their fitting guides, and they refine those over time based on the feedback they're getting from the practitioners in the field. And so the fitting guides are not a bad place to start. Some of them will look at what the keratometry values are. Some will look at what their sagittal depth values are. Some will look at the shape of the eye and say eyes that have sagging cones. If you look at the eye in profile, sort of a Munson sign look at things. Do you have a steep curvature, a flatter curvature, or a relatively inferior location to the apex? So different manufacturers have different guides. And what I tell my students when they ask me, and they say, well, what's your favorite lens to fit? And I said, well, I've got more than 24 scleral lens sets in my office, and I can fit them all, but I didn't start out by learning 24 sets at the same time. So what I would tell you is pick one, maybe two sets to start with, master that set, and then select additional sets to add to your collection based on specific problems that you were trying to address that you found the set you had wouldn't address. So learn that set first, and then you can branch out into more complex sets for specific reasons as you go. One of the things that we've learned from a variety of different studies out there, and I've cited just one of them here, but there are a number of different authors that have came up with the same values here, is that the standard ocular sag, and so this is the sag at the either 10 or 15 millimeter chord of a cornea, regardless of whether you have a regular or irregular cornea, is about 3,700 microns. And then if we add an additional amount of clearance to get to the apex of the cornea, then we see something that's more like 450 additional microns. So basically, the difference, in other words, of the sagittal depth that you're going to see is not the difference from the 15 millimeter cord up to about 3,700 microns. The difference you're going to see is going to be from going from that point forward to the apex of the eye as to whether you're dealing with a normal or an irregular cornea. So that may be kind of confusing here. So let's talk about sort of an example. So if we take the average cornea, whether it's irregular or not, then at the 10 millimeter, if we draw a cord across the cornea at the 10 millimeter corneal sag, and we go from the bottom half up to that sag, from the base up to that sag, then we're going to find that there's about a 2,000 micron sagittal depth. Now, we don't know what that difference is going from that 10 millimeter cord up to the apex of the cornea, because you may have a very irregular cornea, you may have normal cornea, and you may have individual variations in between on that. So then we can actually measure with things like the Pennicam that we have in our office, but you can also do this with other topographers that allow you to measure that corneal sagittal depth. I know we've got a med mount that we can measure that with as well. We can then measure from that corneal sag point forward to the apex, add that on to the 2,000 micron clearance, and then we can also say, well, how much do we need in a tear reservoir thickness to allow for settling? And you might pick 450 microns, you might pick 350, and then you can add that on top. And so that gives you another way of sort of estimating. But there are a lot of variations because we don't necessarily know what the manufacturer's stated sagittal depth on their lens. Are they measuring that sagittal depth based from the apex of the lens to the overall corneal diameter, or are we measuring to the transition zone? And different manufacturers will state the sag of their lens at different points on the lens. So that makes it kind of confusing, and it makes it difficult to apply this kind of rule of thumb as to selecting the first lens. So be aware that that's a complicating factor. So we talk about what's called the functional diameter of the lens, or functional sagittal depths, that are related to the cord length being set at the transition zone rather than being set at the overall diameter of the lens, and that's going to vary your sagittal depth significantly. So I know that's rather confusing to see without an additional diagram in there, but just recognize that there are certain constants like this 2,000 micron distance that are the same whether you have an irregular or regular cornea, and it's the difference then from that cord length forward to the apex of the cornea that varies, and that we can measure using various devices to get it set. And as the picture on the right-hand side suggests, if you flip a coin and you just simply pick a lens out of the middle of your trial set, you've got a 50-50 chance roughly of needing to go steeper or flatter from there in terms of your sagittal depths. So once you get the lens on, you're going to be able to make some judgment. So there are a variety of different ways to select your initial starting lens. Your fitting guide is always a good place to start. You can try and get more scientific from there, but it's going to be confounded by a number of variables because you don't have things like a symmetric scleral profile that complicate the fit of the lens as well, and the lens may or may not center for you. So these are some of the basic considerations that you start to master as you're learning each individual lens set. So let's talk about lens settling for a moment here. So this is an actual patient of mine that we fit, and you can see the measurements, the biometric measurements there in terms of the settling that occurs in the first 30 minutes versus the first 2 hours. So there's no agreement on how much settling actually occurs. There are a range of values that are reported out from 80 microns or less or 100 microns or less on up to 200 microns or more. It just depends on how long you let things settle. There's been some thought again that if we remember the formula for pressure, that it's force per unit area, that smaller diameter lenses may settle more than larger diameter lenses do. And we have seen this in some of the studies, the study that was done by Matt Kaufman while he was with Ed Bennett at the University of Missouri St. Louis in his residency program, did indicate that the smaller diameter lenses actually did settle more than the larger diameter lenses. And this is going to influence whether or not that lens is sealing off on the edge, whether you've got focal areas of compression or impingement, or whether you have generalized areas of compression. So how the patient looks in the first 5 or 10 minutes in your chair is not going to be how they look after they've worn the lens for several hours. This is why we like to have the patient come back after they've had the lens on for several hours before we make any adjustments to that lens. As long as you have any clearance at all, you're probably doing fine from a hypoxia standpoint. But when we start thinking about a lens after 2 or 4 hours or more, it's going to look different. And it's interesting because this compression is not linear. And again, as you look at some of this data that's been put out by Steve Vincent and others, that we see most of this settling occur within the first 2 hours. And so that we tend to tell our patients to come back with the lenses on for at least 2 hours for their progress visit. But when we're doing the initial fit, we're going to have that lens sit on the eye for at least 20 minutes before we finalize our order and order that first lens. That'll save you time in having to do refits down the road. But they've also found that the lens settling goes out beyond the time that's even been measured in the study. So studies that have measured it out to 8 hours, we're still finding some degree of settling. But also when you look at patients and how they look after 1 or 2 months of wear, we find that there's an additional amount of settling, albeit a fairly small amount, that occurs even 1 to 2 months out after they've had it. So what's going on there? Well, the compressibility of the surface tissues of the eye and the bulbar conjunctiva and the substantia propria and all the areas underneath the conjunctiva, all of that tissue is individually variable from patient to patient. So you may find that patients may lose a little bit of clearance going out even 1 or 2 months out after you fit them for the lenses. So it's an interesting kind of exercise trying to predict the amount of clearance that is occurring. But most of your trial sets are going to recommend that you let the lens sit on the eye at least for 30 minutes before you look at this variability. So I see we have a few questions on that point. So let me take a look at some of those. So one of them, I see one, does the VN, I'm assuming that means vault, vary over time with a perfectly fitted scleral lens? I think this slide kind of answers that yes, it can vary over a period of months even, but is it clinically significant or not? Not so much once you have a well-fit lens. As long as you allowed enough space in there for settling, you're not going to have a problem with that. But I have had patients that have had low clearance lenses that went out and had an initially good fit and only to come back where it was not very good after about a month or two. And what's going on there? Well, we talked about the individual compressibility of the tissues, but if you've got a patient like a cone, you may actually have a progressing cone, particularly in a younger patient. And so not only is the lens coming down to meet the eye, but in a sense, the eye is coming up to meet the lens on some of these progressive conditions like the ectasias. Let's see. Just scanning through quickly to see if there are other questions I need to address here. What is the minimum time period to discontinue scleral lenses for keratoconus cases if we want to check progression? I always look at that as a snapshot in time. So there is discussion in the literature about sort of a washout period. Particularly, I'm assuming that this may relate to questions about corneal cross-linking, which is an interesting subject. What we do know in general about corneal cross-linking is we're not sending enough patients soon enough. So charting progression is important. We're always checking the topography at each visit that they come in with. So I'm not so concerned about whether they take the lenses off and discontinue for a period of time in order to assess the progress than I am with checking it the same way at each visit. So if you're not discontinuing the lens wear and you're looking for progression over time, as long as you're checking it the same way at each visit, you're going to see that progression. And if you're fortunate enough to have devices like the Pentacam, where you can actually look at posterior as well as anterior changes, then you're going to be able to see that progression occurring in terms of changes in pachymetry as well as changes in posterior elevations and so on. So if you're a purist and you want to have the patient go through a washout period, leaving the lenses off, it's not very practical for many of our patients because they need this lens to restore their function. And so taking the lens off and letting them get back to some baseline that you had before you fit the scleral lens just may not be a practical issue for you there. So I think you run into that practicality measure as you go through there. I think those are really good questions. Anything else that we see there that we need to think about? Let's see.
Yeah, we could, if you don't mind, we can take the questions later if you would want to continue the session. And
okay.
Yeah, that would, because there were a couple of questions before as well, so we could address them. Yeah.
I think
okay.
most of the questions are going to be covered in the later sessions also, so we can take up the lecture more importantly.
Thank you for that, because I don't want to take more time than I have allotted here, keep people on too long too, because we've got a fair amount to cover yet. So let me go through and just summarize the clearance values that you see for predicting clearances and differences by diameter here in this chart. That basically you can see that range of value in what they refer to as central sync or settling range all over the board here, but very few of them go over 130 microns or so. So our principle 5, you want to clear the corneal limbus 360 degrees around. Again, some of the reported settling ranges there range between 50 and 100 microns. And the rationale there is that you're trying to save the stem cells at the base of the palisades of oak from any damage that may occur and inducing things like limbal stem cell deficiencies. We actually fit these lenses on patients that have limbal stem cell deficiencies, so it's not necessarily a contraindication, but the problem is that if you're mechanically irritating these cells often enough and badly enough, you're going to impair their division and progression from that center out towards, or from the periphery of the cornea, migrating in centrally and then vertically. So you want to have some clearance out there for that reason. Excessive amounts of clearance there, well, it may actually lead to things like hypoxia in the limbus as well. And we've seen lots of good pictures at meetings of folks that have microcystic edema from excessive limbal clearances. So it is possible to have too much clearance out there as well. One of the ways that you can check for these things is, remember, when you take the lenses off, you want to stain the eye as well and see if you've got mechanical irritation. So here's a patient in the upper left in a white light view. You can kind of see in the specular reflection that surface is sort of mottled and dull. That's actually a sign of some of the microcystic edema occurring. And then you can see an indentation ring under the cobalt filter of where that transitional zone junction actually sort of left an imprint or impression on the cornea of where it had insufficient clearance. And then you can see some staining out there that corresponds to those areas that we talked about. And also, if you're getting compression out there when you take the lens off, sometimes you'll get a rebound hyperemia. If you have absent those mechanical signs of a problem where you have insufficient clearance, excessive clearance, you can see when you do an OCT of an anterior seg, a lot easier than you can looking in white light, say. And you can also see some conjunctival prolapse in this image here. And again, you can manage these things a number of different ways. You can steepen the base curve, which tends to also create greater transition zone clearances. You can increase the width of the transition zones in some designs, and you can also increase the diameter of the lens. Remember, larger diameter lenses for the same base curve will have more sagittal depth clearances too, so you may have to adjust your sagittal depth as you're doing this, but it's a way of sort of pulling the lens away from the limbus by increasing the diameter as well. So our sixth principle here is avoiding compression and impingement, somewhat related to what we just talked about. So here we're getting from that transition zone into the landing zone, basically, of the lens. And we want to strive for kind of a symmetric, even pressure all around in the landing zone with no bearing in one particular area. You can see here that you're getting a little bit of compression in this landing zone in the upper left-hand corner. And you can look and see with staining after you take the lens off, are you mechanically irritating that surface and causing a loss of cells or not? And here you can see that that is causing a loss of cells. So that's further confirmation. You can look at the large vessels, and as you see the one coming in at about 9 o'clock there, as it transits across the edge of the lens, the column of blood is interrupted until it gets to the transition zone, and then it starts up again. So you can look for that kind of blanching that tells you that you've got compression there. And certainly you can, if you have access to an anterior segment OCT, you can get an even better cross-sectional view. And here what I've done is I've split the edge for you at that yellow dotted line, and having an edge that comes to a soft landing where no more than half of that is buried is an acceptable fit. But as you see here, more than half is buried, and you've actually got the red line indicating the surface of the lens out there aligning with the conjunctiva. So you've got basically the full thickness of the lens is buried there, and you can see that that's an unhealthy situation for the eye. So again, you can increase the diameter of the lens to overcome that. You can also change the transition zone relationship. Some designs are convex, which is the most common, and you can have some lens designs that actually have a linear connection between the transition zone and the landing zone, and some of that can be manipulated to give you greater clearances. And you can certainly flatten those landing zones and edges. You may go to a toric landing zone too, which is increasingly common. And the reason that it's common is that if we look at the scleral profile itself, we think it follows the pattern of the recti insertion here, that spiral of Tillot that we learned about. And actually about almost 2/3 of the scleros that you're going to encounter out there have some sort of asymmetric profile or toric profile out there. And only about 6% are going to have a spherically regular scleral profile. So if you were going to take a bet, you would bet that you're going to encounter a need for a toric peripheral curve more often than you do a spherical peripheral curve. And this picture here kind of shows you where you have that bearing in the landing zone because of this asymmetry that's on the sclera. And it's also a reason why lenses tend to decenter. So the sclera is actually a higher on the nasal side and flatter than it is on the temporal side. So if we look at this picture from an article that Dr. Fidel so brilliantly wrote on, you've got a very, very nice picture here that shows that asymmetry and shows that difference. And that's why lenses typically, even your soft lenses, if you look at them, will tend to decenter temporally and inferior a little bit. And this is why that occurs. And if we look at this picture here, you can see the cord lengths we were talking about, whether it was a 15 millimeter cord or a 10 millimeter cord, and measuring from the base up to those lines is always 2,000 microns. And from there to the apex of the cornea then is the difference. So I'll just point that out briefly. On the right-hand side here, this picture, you can see as I rotate this SMAP 3D image that the corneal shape and the scleral shape varies. And in a normal lens that you put on the eye, you're going to have, sort of the thinning at the apex, and you'll have a great deal of pooling at the base of a cone, for example, and you're going to have an uneven tear reservoir all the way around. Well, this can affect the optics. It can affect the lens tolerance and concerns you have with hypoxia. And what this type of technology allows you to do is to create a uniform tear thickness all the way around under the lens by customizing the shape of the lens. That's something that you can't get with a stock lens. And what's interesting is when we connect the corneal cap to the scleral profile, 80% of the time, that's going to be a linear connection. It's not going to be convex or concave. The shape of the corneal irregularities in terms of where the major and minor meridians are, the flat and steep axis, don't align with the steep and the flat axis of the sclera. So you can't really make a prediction about that when you look at that using only topography data. So in Principle 7 now, we're out to the edge. Again, we talked briefly about that edge not being buried, as you see in the upper right-hand corner. And we talk about it not standing proud of the surface either. Those tend to be uncomfortable fits for the patient. And I like to ask the patient when they come back, if the lens is uncomfortable, can you point to where it's uncomfortable? And patients are usually pretty good about pointing to where an edge is standing off too much and generally point you in the direction of where you need to be looking with your slit lamp. And you can look for the shadowing that occurs in the edge from that edge lift and standoff to tell you that that's what you've got going on. A well-fit lens like the one in the circle down below is no more than 50% of the edge buried or above the surface. So that's kind of evenly distributing the weight. Interestingly, lenses that have insufficient clearance generally start out to be very comfortable because the eyelid's not blinking over that edge. But as they wear it for a number of hours, it becomes increasingly uncomfortable for them. And so these are folks that, again, towards the end of the wearing time, will tell you that it's just getting more and more uncomfortable. And when they take the lens off, often they'll tell you that they've got a red ring around their eye where they get this rebound hyperemia. So we talked a couple times about tear mixing and tear exchange being important. This helps bring in oxygen and flush out debris, but you don't get a lot of tear mixing. You don't get a lot of tear exchange. These are semi-sealed systems, unlike corneal lenses where you've got a good 20% or so that it's exchanged on the blink, or even a soft lens where you get maybe 1% exchange on the blink. Here you're talking about something like 0.8% per hour. So it's a fairly low volume of tear exchange that's occurring. But if we're looking for complications again, look for infiltrative events. That's what the yellow arrows are pointing to. And you can actually see where they're starting to break through in the epithelium in the fluorescein picture to the right. And so you may have to change your clearances again. You may not have allowed enough leeway for the settling times, and you may have to change the geometry of that landing zone to mitigate all of those things. One of the things that we can do, again, since we know that we have this 2/3 or so of the scleral profiles that are asymmetric, here you can see the edge of the lens on one such design that's customized to fit that it's got sort of like a rippled edge to it. This allows you to more closely align the shape and profile of the sclera, but in doing so, you're going to reduce your tear exchange a little bit too. And so just know that that's going on. And obviously, we've got more going on to bring oxygen in than just tear exchange. We've already talked about that, but it can take a very long time to exchange the tears in there. Our eighth principle is really the final one, talking about the over-refraction. We talk about steeper add minus, flatter add plus when we're doing corneal lenses. And it's relatively easy on a regular cornea to do an over-refraction and adjust that. But in irregular corneas, you can't do that. And again, sagittal depth really determines this a lot with scleral lenses. And certainly if you change the base curve on the scleral lens, you can adjust the powers using the same rules of thumb clinically, but we can alter that sagittal depth, sometimes 150 microns or more, before it actually changes the power that's required to give full correction in the scleral lens system. So we don't have a good rule of thumb like that because we're dealing with thick lens formulas and a lot of irregularities and ups and downs in the cornea, but it's sort of a balancing act here. And what we're saying, again, is a move towards more customized lens designs using aberrometers now with at least one company here in the US where we can actually transmit those aberrometer values and get a wave error correcting lens generated from it. We know that coma, for example, in keratoconus patients is more important than some of the other higher order aberrations. So you don't need to correct all of them. You only need to correct those that are most relevant for the patient. And when we talk about doing trial lenses and autorefractors and phoropters, those are designed to measure the lower order aberrations, which are about 90% of what is present in a normal eye, and only 10% are the higher order aberrations. Well, you can greatly upset that balance when we're talking about that in patients that have scleral lens wear. And you can get these as calculated values. Many of your topographers will do that. You can actually do Hartmann-Shack wave aberrometry if you're so fortunate to have one of those, and even tomographers have them. So the guiding principle is start with simple things, do trial lenses outside the phoropter. If you have a more regular eye, you can do it in the phoropter. Autorefractors aren't going to be as helpful because they're designed to measure regular astigmatic changes, but they can give you some clue as to what sort of changes you may want to make. And I do over refraction sometimes with autorefractors, particularly to show decentration and with multifocal patients. And then the aberrometer down there in the lower right-hand corner reminds us that that's kind of the pinnacle of things. Lens treatments and coatings. Here we're talking about just things that are really just hyper cleaning the surface is what a plasma treatment is. It's not an actual coating. And as soon as you handle or manipulate the lens, it's thought that you've kind of defeated the purpose of that hyper cleaning of the surface, and you'll start attracting things to the surface of the oils on your skin and that sort of thing. But it does help take off some of the waxy pitch and things used to polish in the final surfaces and mount the lenses to the lays. It can remove those impurities that cause the lenses not to wet well. Some manufacturers ship their lenses wet, other ones ship them dry. And I think we've all had lenses that maybe weren't properly cleaned or cleaned enough before we put them on an eye, and you can see the tear film beating up on the surface of the lens. So it's a relatively short-acting thing. We do have one actual true coating out there, Tangible Sciences Hydropeg coating that uses a polyethylene glycol based hydrophilic coating. That does help some patients with comfort. It does help patients with wearing time. There's not been a good large prospective study that shows a superiority over uncoated lenses to where you would want to do this on every lens. But there are certainly patients that have dry eye problems that can benefit from this and improve their comfort throughout the day. So it's something that I add to a lens judiciously based on those considerations. Once you put that coating on, though, you immediately eliminate the ability to use alcohol-based solvents or abrasive cleaners. We never use tap water on any of our lenses because of the risk of acanthamoeba, but patients need to be reminded of that frequently and know that if you're doing that, you'll strip the coating off. There are some solutions now that they have available from the manufacturer to help prolong the wettability of these coatings. Salines for inserting the lenses. For a long time there, all we had were things like inhalation saline that we would use, mixing it up for asthmatics that had to use albuterol or that sort of thing. And now we have some actual FDA-approved salines out there. Here are 3 of them. The neutrophil is the only one that has an electrolyte balanced formula. There are some differences there for some patients, and some will do well on one and not the other. We've run into supply chain issues. I don't know if you're experiencing that in other parts of the world, but we've had some issues trying to source some of the products that we get from overseas because they're sitting out in the port of Los Angeles right now, and we're waiting for those to get to the U.S. Some manufacturers have actually started making their own with their lenses and including those in their lenses. We avoid those things with preservatives because we're trapping those against the surface of the eye for 12, 14 hours a day sometimes, and that can cause damage to the corneal epithelium. We have aerosol salines, but if you use those aerosols, it's hard to keep the lens stable and not blow the lens off your fingers or off the plunger if you're using an aerosol. But they also put the propellant in there, creates bubbles that you trap in the reservoir. And here's what it looks like if you have preserved agents. This was a patient of mine that used a multi-purpose solution because it was less expensive than getting the salines to insert their lenses, and they filled their reservoir with a multi-purpose solution and ended up with this toxicity on the sclera. It's very much like we used to see in the old days with thimerosal preservatives. And then just kind of to close things out a little bit, you have a variety of tools for inserting the lenses. Some have illuminated devices and LEDs to help the patient line up because many of these patients are in the low vision range without their lenses on. And we have some just plain plungers you see over on the left-hand side. We like to cut the bottom off the big plunger so that it doesn't suction to the lens for the patient to put it in, but it's not essential, but they do have to remember to squeeze to release the plunger then. I've had patients that had arthritis that couldn't do well with that, but they could retract their lids. And so I poke a hole in a styrofoam coffee cup and stick the big plunger in there to support the lens to free up their hands to be able to use those to retract the lids. So you can get very creative with these things. There's lots of different devices out there. And I think the one thing that I like to tell my patients is one of our colleagues, Karen Lee, who's down at University of Houston, has an excellent video of a patient she had that was born with a congenital anomaly that had no hands at all. And this individual is able to insert their scleral lenses and remove their scleral lenses without having any hands. And so they're able to manipulate these things well enough with what they have to do it. So that gives, I think, incentive or encouragement to the rest of us that we can do some miraculous things if we just have enough patience and time to do it. And then the last thing I'll leave you with here is a promotional message that beyond the resources provided in this series of lecture, which are going to be great for you, you can find an archive of webinars and other resources for you and your patients at the Scleral Lens Education Society's website at sclerallens.org. I'm also an advisor to the Gas Perm Lens Institute. They've archived over 100 webinars that go over a variety of rigid lens concerns, including scleral lenses, and we partner with them to share resources as well. And you can become a member of the Scleral Lens Society just by signing up. You can go through the fellowship process that's explained there as well, and we'd love to have more fellows as well. So I'll turn it back over to our moderator and see if we want to do any more questions or Q&A.
Thank you so much, Dr. Daniel. I think you covered majority of the things. You gave us a gist of almost everything which we need to know about fitting from, in the lens selection, and towards the end about over refraction and how to advise patients on insertion removal and all of that. So thank you so much for taking up this time and doing this session for us.
Well, it's my privilege, and I know I ran long on time there. It's a lengthy subject to cover, but thank you for indulging me and letting me take that additional time.
Sure. And I think most of the questions which we have received are, going to be covered well in detail in the future sessions. So the first question, I think, which came very early on, I'm just going to share that with you, is you mentioned about retinal surgery being a contraindication. So any thoughts over it? Why and what would we do if we have such patients?
Yeah, it's kind of a vague term. When we say retinal surgery, obviously you have things like VEGF injections and you have laser pexy and you have things like scleral buckle. So these would be procedures that actually distort the ocular surface, really more things like buckling and bands. And certainly we see less of that today than we used to back in the early days of those kind of retinal detachment repair surgeries. So that's what that's referring to.
All right, great. And coming back to the same line of question, in terms of glaucoma shunts patients having operated and implanted with shunts, what would be the ideal choice of these overall diameters? Do you want to fit them larger or they should be smaller in diameters?
It's hard to generalize because they're all different. We certainly have had larger lenses that were needed because of maybe irregularities in the cornea itself that we were trying to overcome. And, keratoconus patients end up with glaucoma sometimes too. And so you have a balancing act there. And what we find is that if you have a shallow bleb, sometimes you can vault over those with the little micro vaults in the edges and lift up over those areas without compressing the bleb. Sometimes you can do a notch on the edges there in a larger diameter too to get around those areas. So you can go smaller or larger depending on the needs of the patient and the topography of the cornea and curvatures of the cornea. So it's hard to generalize. The one thing you do want to avoid is you do want to avoid thinning that bleb out by rubbing on those. And one of the things the patients have a challenge with is trying to get that notch in the right orientation so that it is straddling that bleb. And many of the manufacturers will put a black dot on the lens at a position that should be put at 6 o'clock. And sometimes that's easier for the patient to see. And I've done that with a Sharpie marker before too to help highlight that so it assists them in getting the orientations right.
That's right. All right. And a couple of more questions. Again, any tips, when we have these ocular surface disease and dry eye patients, their palpebral fissure height is a bit smaller. So, when you insert these larger lenses, it's a bit difficult. So any tips on diameter selection for these patients or lens insertion tips?
Yes, as I was reading that, I was reflecting back, especially in the early days, say a dozen years ago or so, where the ophthalmologists were starting to really be excited that we could offer these technologies. I had a host of anterior seg surgeons that were sending me these patients, and they would send them over with the tarsorrhaphy still in place. And in some of the tarsorrhaphies, I was able to work around and get a smaller diameter lens in, like a 14/8, but that's not always practical for each patient and their needs. And certainly if they've got cicatricial changes and they have all kinds of adhesions, you may have to say, well, I think I can do this, but what we need to do is we need to have you excise those bands and release those, or you may have to take the tarsorrhaphy out for me to fit them, and then I'll send them back over the same day and you can put it back in. So you do have some particular challenges in working with patients that have either anatomically narrowed fissures or that have surgically narrowed fissures or that may have a lot of adhesions. And so the one tip I would give you is that good communication with your specialist is really helpful in trying to work as a team together to meet the patient's needs.
Awesome, great. And is there any guidelines or recommendations when it comes to climate versus the decay selection? So in this particular case, they are talking about decay value for hot climates. Do you have any recommendations for us?
I don't have anything that's evidence-based, but it's an interesting question, and I think it's just the same way that folks at altitude may have greater concerns than folks that are at sea level, say.
Okay.
It just hasn't been studied well enough to know for sure how to advise you, but I'm sure that, humidity and that sort of thing is concerning in some respects. Certainly folks that live in arid environments, we're more concerned about ocular surface disease with them. So it makes sense that there would be some concerns there. but not anything that I've seen that's reported in the literature to any large degree.
Great. And one last question before we end the session for today. It's about more towards complication related, but since you mentioned about epithelial bogging, do you think it has any short-term or long-term effects, and how could we solve that problem or complication?
Yeah, it's an interesting thing. It's thought to be a benign condition overall, so not something that necessarily needs to be addressed. I think those may be patients that if you're seeing it consistently, maybe would benefit from something like neutrophil that has the electrolyte balance versus things like inhalations, salines that may not be designed with the corneal surfaces in mind. So I would certainly try switching them to neutrophil. Long-term consequences of physiological compromises. But again, I think you have to individualize that to your patient. You know, I'm going to treat somebody with neurotrophic changes or limbal stem cells differently than I'm going to treat a keratoconus patient, for example.
Great. Okay. So I think we'll keep the other questions for the future sessions, because those are questions which I think are related to the future talks. So those who have asked the questions, don't worry, we'll address them as we go along the course.
Most of the time it is seen that, as you had also mentioned, that you start with 1 or 2 sets, and then of course there are patients that even today that none of those sets would fit in, you know. It's a common experience seen here, especially with our countries, that we have very limited availabilities. You hardly have 1 or 2 design manufacturers supplying to us, and investment is in the sets are very limited. So a message on that definitely to all, because they just try to cover up whatever available resources they have and just fit the patient. After going through your session, it makes it very clear that there are many complications and troubleshootings which are required, and not one set may be good enough for fitting the whole range of it. So anything you'd like to add on that?
I think that's very well stated, and I think you know, access to these technologies around the world, as you say, is very different depending on where you are. But certainly, as a movement, what we're seeing is a move from stock lens designs towards more and more heavily customized designs. And I think there's at least some preliminary evidence that shortens the number of lenses that are needed to fit a patient and makes the process more streamlined, which is less frustrating for the patient and less frustrating for the doctor, I would say, too. But I think that's, you know, this is where I think we have an important opportunity for advocacy among all the different groups to promote the education, to work with our industry partners, and try to grow this specialty as well. So I think doing things like we're doing today and doing things like our respective organizations do is really important. And we're stronger together than we are apart. And so joining your organizations wherever you are and being part of those and you know, being part of the group that's pushing the frontiers forward, I think is really essential for helping the number of patients that we have and bringing access to care to the patients that need it.
I think that's the ultimate aim also, so that the industry gets attracted and we have more and more practitioners giving them back the business in return. Thank you so much. Fakhruddin, I think we will have a quiz at the end too.
Yeah. So with that, I think first of all, let me take this opportunity to thank you, Dr. Daniel, once again for that wonderful session. I know we went over time, but then I think we were all engrossed with the talk and learning, so that's okay.
Every minute was worth it.
Well, thank you, and you're very kind. And I never use one word where 10 won't do as well. So, so I run a little long, but thank you for indulging me and for the privilege of addressing the group.
Thank you.
Most welcome. So take care, everyone. Be safe, and I wish to see you for the next session, which is next week on Friday. Take care, be safe, and see you next week. Bye-bye.
Thank you, everybody. Thank you, Dr. Daniel. Excellent session. I think you covered the whole scleral and summarized it very well.
Thank you so much.
Thank you so much.